based management of patients who are on these medications in the procedural period. So low back pain is the leading cause of disability worldwide, should be a priority for future treatment in regards to research and prevention, therapy, but also in conjunction with the patient's comorbidities. A lot of interventionalists tend to see the problem as just the low lumbar spine problem, just the cervical spine problem, but in a growing aging population where the fastest population subset is that over the age of 65, really have to be very careful how we manage these patients in terms of the comorbidities that they certainly have. My disclosures, nothing financially relevant to the talk here, but it is a personal interest to me in regards to this topic. It's something I've been involved in for about 7 or 8 years now. Presented some of this research that I'll be talking about later that I was involved in, some of what we have published previously. And then again, it just becomes or stems from an interest that has developed due to events that occurred in the past. Want to acknowledge my mentor, Dr. Michael Furman. Him and I have worked on several pieces regarding this subset of periprocedural management, and I would not be here without him. He's been a really great guidance, mentor, teacher, and friend as well. So we'll review the current consensus statements. What did the guidelines that are out there, what did the society say? What are the current published protocols? Examine the true risk of what the bleeding complication is. We're going to talk a little bit about how to formulate an evidence approach and kind of summarize some things. So the major and the most popular and the current in use guidelines come from ASRA, which is the American Society for Regional Anesthesia, and these were published in 2018 as the second edition, a consensus statement of other organizations, and they base their consensus and their recommendations based on procedure risk. Is it a low risk procedure for bleeding? Is it an intermediate risk procedure for bleeding? Or is it a high risk? But there's really limited consideration of what the thrombotic complications are if you do say hold the medication prior to an interventional procedure in a patient that has medical comorbidities. And the way they stratified is high, intermediate, and low. Now, low risk procedures, your peripheral nerve blocks, SI injections, trigger points. Interestingly, cervical facet interventions, and I'll make a distinction why I'm pointing that out right now, is in the intermediate risk group, which is the same as interlaminar and transforaminal epidural steroid injections. And from a technical standpoint, they're very different procedures. And the management of them in regards to this risk stratification may be a little bit too simplified. Some of the drugs, because of a high risk of bleeding, would involve stopping the medication. And here's the graphic from the ASRA guidelines from 2018 in regards to both high risk, intermediate risk, and low risk procedures. As you can see, low risk procedures don't really require cessation of any significant medications. However, low molecular weight heparin, fibrinolytic agents, they do require stoppage. If we keep on going, other common and often seen are seen in this table, where again it's stratified by high risk, intermediate risk, and low risk, when to stop and when to restart. I'm just giving you introduction to this, just so you're aware, but this is what a lot of people use, but it is not by any means the only guideline or consensus statement or publication in regards to management of these medications in the interventional procedure population. A little older data that came from Kansas ruled that the risk of thromboembolic phenomenon is higher than the risk of epidural hematomas when discontinuation of antiplatelet therapy prior to interventional techniques. And why epidural hematoma? Well, that is the major complications they're really trying to avoid, especially with epidural steroid injections. You at first want to do no harm. So when you're doing these procedures, the last thing you want to do is create a complication which we as interventionalists are not able to deal with, and that is an epidural hematoma that may or may not require surgical evacuation. Now, there are cases of subclinical hematomas that don't cause clinical symptoms, but these aren't the really high complication causing symptoms, which is why it's really something they need to be aware of. So again, deferring evidence for should we stop it or should we not. This was a study, two studies actually. One was done a couple of years ago, and there was recently an update where they looked at thousands of patients and found no hemorrhagic complications, but prevalence of medical complications was higher in the patients who stopped warfarin. So now we have to start thinking, well, we have reflexively been stopping these medications. Oh, you're on aspirin, stop it before the injection. You're on warfarin, stop it before the injection. Oh, you're on Plavix, oh, you have to come off of it before we do the injection. But is that really the best practice? What evidence shows us? What is the risk of bleeding in combined with the risk of medical thromboembolic complications? What is the risk benefit? Are we having these discussions with patients? Which is better? Is the pain so severe that maybe doing the injection on an anticoagulant is warranted because the symptoms are so functionally limiting and the patient is not able to stop a certain anticoagulant? So just different ways of thinking about what the best management of the patient is. Not necessarily what's best for the injectionist or the interventionalist or the pain management physician, but what is best for the patient when you consider all the risks, including bleeding and thromboembolic events when the patient is or is not on a medication that creates an antiplatelet or an anticoagulant effect. Going down the line, Brad Goodman, who's in Alabama, who's a good friend of mine as well, they published a paper outlining what the management of these patients are. And again, their conclusion when they're looking at their own data and their own practice data is that continuing antiplatelet and anticoagulation medications for intermediate to low risk procedures may be advisable. Now, again, the low risk and the intermediate risk, as we have discussed before, according to the ASRA guidelines, do include epidural steroid injections. So even for epidural injections, we may not need to stop some of these medications. Now, this makes perioperative management a lot easier. Patients are not confused about the medications. You can easily tell them to take every medication that they need to. Don't worry about it and things like that. Also, with increasing circumstances regarding the lack of necessity for IV sedation for these procedures, it's even an easier management protocol where if they're not getting IV sedation and you don't have to stop any medications, they just come in, get the injection and go home. It could potentially technically be as simple as that. Another review, this is from the Spine Society, Intervention Society Standards Division, where they took a look and they did a systematic review of all of these publications looking at bleeding and thromboembolic event risks. And what their conclusion was that even for interlaminar, other than for interlaminar procedures, the evidence does not support the view that anticoagulant and antiplatelet medications must be seized before image-guided spine pain procedures, even for some interlaminar procedures. But I will agree that if there's a patient that can come off on medication safely and is able to without putting themselves at risk, that would be beneficial for interlaminar procedures. However, for most other injections, including transforaminal epidurals, caudal injections, you may not necessarily stop it because the evidence shows that seizing anticoagulants carries a risk of serious consequences, including death. And what really drove my interest in this topic was when I was a fellow, and this was back in 2013, it was a patient that was on the schedule. It was an interesting procedure. It was a post-laminectomy syndrome, multiple level fusion, and we were going to do a epidural injection. And I read up on the case. It was early in my fellowship career, so try to read as much background and making sure I'm aware of the case. So when I am doing that procedure with the attending, we can have a more thorough discussion while the procedure goes on, but then we hear the patient canceled. So as a good fellow, I called the family like, hey, we saw that your dad canceled the procedure. And the family member said yes, because he passed away. So why did this patient pass away within several days of the procedure? Where we look back on the records and we stopped his Plavix 7 days prior to the procedure. So I don't have the cause of death. I don't know if there was an MI or something else. However, the question that remained and what really started this process, both with myself and my mentor, was, did we create harm by stopping Plavix when maybe we shouldn't have? So the risk of stopping it can be quite significant. We look at our data, and this is from Dr. Furman. It is the incidence of ischemic and hemorrhagic complications associated with ceasing and maintaining anticoagulant and antiplatelet agents for pain interventions. And we're looking at, for image-guided interventional procedures, the risk of stopping versus continuing these medications. Because like I said, there is growing evidence that the risk of stopping sometimes outweighs continuing them. So what does the data really show? Well, the study duration was for 8 years. It followed a total of 63,592 procedures. Now, if a patient had multiple procedures over this 8-year time period, there would be different data points. So you'd have the same person or the same patient, maybe several procedures over an 8-year time frame. There were 5 lost to follow-up. Out of the 63,000 total procedures, 6,300 were taking a pre-procedural anticoagulant or antiplatelet, and those 6,300 were followed closely with 90 days follow-up. And out of those 6,300, 2,500 ceased, 4,000 maintained. Here's a little bit of breakdown of our data. Cervical interlaminar, caudal epidurals, you can see the total numbers of injections and procedures that were done. A busy multi-specialty spine practice over the course of 8 years. And the evidence for clinically significant bleeding or epidural hematomas was not there. The incidence in the literature is somewhere between 1 in 65,000 to 1 in 160,000. So could we have missed 1 or 2 because we did not have a high enough N because we only had 63,000 patients? Maybe. But what happened to those patients that actually stopped? Well, that's the interesting part, is we had significantly more complications in the patients that stopped these anticoagulants than we did any kind of significant clinically bleeding risk because of a complication of a procedure. And this is really the most important slide, because these patients ceased this medication, had the injection, and within 90 days had severe significant complications, including strokes, MIs, even several deaths. Now, was that our leading cause of death? That is yet unknown, which interestingly is patients that maintained their complications also had complications. Patients that were on an anticoagulant or antiplatelet medications were at higher risk from a thromboembolic event. And that partially is due to a hypercoagulable induced state with corticosteroids. A couple different things that really to digest there is the risk of thrombosis, whether you stop or maintain the medication, is significantly higher than any bleeding risk caused by the injection procedure itself. So these patients have to be treated very carefully, whether they stop or maintain their medications, knowing that the complication rates would be higher just by being on that medication. So here's a little bit of a data summary. 63,000 total interventions, 2,300 had ceased, where we had 18 ischemic complications, 4 deaths, and 4,000 had maintained, and there was also 2 deaths as well as 24 ischemic complications. The relative risk ratio of ceasing the medication was 1.298, and the relative risk of ceasing medications and death was 3.46, not insignificant. The number needed to harm was 564 and 817. Again, not insignificant. When you talk about the cumulative percentage of ischemic complications over time, there's this beautiful graph that you can see that as time goes on, the risk does increase. So we have similar hematoma findings as in prior data in terms of about 3 to 100% in terms of incidence. And for cervical, thoracic, lumbar, or even peripheral interventions, the consequences of ceasing anticoagulant and antiplatelet medications only slightly exceeded the risks of continuing them. There were no serious bleeding complications and no epidural hematomas. So do I recommend saying, oh, continue everything? No, absolutely not. Do I say stop everything? No, absolutely not. What I'm trying to say is that we need to get away from reflexively saying one thing or the other. We have to start thinking about it a little bit different way. Why is the patient on this anticoagulation? What is the risk of stopping it? Is the procedure we're doing truly warranted? Can it be changed? Does it really need it to be done? What is the risk of performing the chosen procedure without holding the medication? And for each patient, that should be a discussion, and an analysis for risk and benefit should be addressed with the patient's input and concerns. So if a patient is deemed to be at high risk for a cardiovascular event based on the medical history, then the multi-society guidelines recommend participation in a shared decision-making process, which is absolutely correct. But in addressing a patient's anticoagulant status when considering an injection, it can be challenging because there are risks of thrombosis. And although there's some inherently different limitations in the guidelines, the main objective, obviously, is to enhance patient safety and overall increase and improve clinical outcomes. We must first do no harm. Common pain procedures have a low risk of serious complications, which may be close to zero. However, ceasing them has a low but non-zero risk of serious medical morbidity. So I leave you with a picture. This is our discussion on anticoagulants that has been going on for the last 20 years when we say reflexively stop or continue any medications. However, if you take a step back and you look at the whole picture of patient safety, patient outcomes, you really need to start thinking about a little bit differently. Well, you know what? This patient has 3 stents 6 months ago and is completely debilitated, can barely walk because of radicular pain. Well, maybe we can safely do this injection with this medication on board. But if a patient had a DVT 4 years ago and for some reason is still on a prophylactic medication such as Coumadin or another medication without any other risk factors, then that medication could probably be safely stopped and the interventional procedure can be performed. I hope I, at the very least, allowed you to think a little bit and kind of approach some of these patients in a little bit of a different way. If you want to get in touch with me, email, Instagram, or you could go to my website. But at the very end of the day, just patient safety is the utmost importance, and then obviously outcomes as far as